Dr. Wies, we're trying to remember when she came. I think it was 2003 or 4. Anyway, it's been 6, 7 years. So she came here from San Antonio, where she was in the military. And for more information on Dr. Wies, there's an insert card. It has all of her contact information and her training and on this card. So please refer to that. So we're going to go ahead and get started and let Dr. Wies get going.
Hello, can you all hear me okay? Good. I'll try not to venture too far away so nothing gets kabobbled. I have no disclosures, financial disclosures. I have no agreements with any drug companies or outside sources. I just work for ETMC now, basically. And today we're going to talk about women and heart disease. I tried to pull what I could off the web. Most of the web slides, of course, are a few years old, but the trends you can see pretty good, so I think they'll be helpful. First of all, it's kind of confusing. I want to explain this. When we talk about heart disease, we talk a lot about cardiovascular disease, and that means really the entire body. Strokes, aneurysms, where the aorta is, peripheral vascular disease, where the legs are, the aneurysms are there, and also thoracic aneurysms and strokes in the brain, and of course the heart disease, coronary artery disease. So really when we talk about cardiovascular disease, we include all of these. A lot of people also include heart failure and high blood pressure in that. So when we say cardiovascular disease, it's a whole gamut of diseases, but they're all really vascular diseases. And then I wanted to show you at least one picture of what we're talking about in all those blood vessels I showed you on the last picture. We're talking about that we have some plaque formation here, cholesterol deposits, white blood cells, macrophages. We have a thick cap over here. And the blood, the artery, the lumen, this is the hole is the lumen is narrowed, and that's the only place for the red blood to go through, which is okay. Now, most heart attacks happen in vessels that are not 100% occluded. So a lot of times you'll say, okay, I got a 50% occlusion, everybody feels wonderful, but a lot of the heart attacks are in the 40 to 50% occluded vessels. And that's because you can get a thrombus right here to form, and a platelet aggregate, a thrombus, which reduces blood flow further, and then you have the heart attack. So even if you have a small amount of heart disease, if you haven't had an angiogram or something, you still need to work and try to get some regression of those plaques. And sometimes we can regress these plaques because you want the biggest opening possible. Okay? And here's a picture. Now, undoubtedly, this is a male, and I can tell you that because men have bigger arteries. And so here's an artery. It's occluded right there. And that's part of the difference between men and women. Women have smaller arteries. They're harder to stent, harder to treat. And then here goes the percentage. And the percentage, you can see we've got stroke, which is 17%. But 51%, the big part of the pie here, is actually heart disease, coronary heart disease, heart attacks. And the other vascular diseases are a lesser percent. Now, this is probably this is a cost in billions of dollars. I think this was in 04 dollars. This is just 1 year. Over $200 billion a year for heart disease in the United States, and that's both men and women. So it's a huge economic impact on our healthcare dollar. And here's a slide. I picked out this one. It talks about deaths in thousands. Now, unfortunately, the ladies are in pink and the men are in blue. And you'll notice in 79 the ladies were lower, but now the ladies, as we have the older population, they have more deaths for heart disease than men. So that's not good. I mean, but they're both trending down. So notice how they're both going down. That's good news. We've made some progress. Okay, now heart disease is the major cause of death in women and of all causes. And this is really important because you hear so much about cancer, strokes, but heart disease is more deaths due to heart disease than all other causes combined. And here they total the total coronary vascular disease and the coronary artery disease. So especially as women get older. And so heart disease, if you're over 65, 1 in 3 women has heart disease. very, very common, 80% at 80. So it's very common, and we want to try to treat that as best as possible. Now here's mortality, and you can see that the women in the out years, there's of course more women with the baby boomers, but women have a higher mortality in the more recent years than in the earlier years. So women are definitely catching up to men with heart disease, and that's why there's been such a big focus in February from the American Heart Association on women and heart disease. And here's I just told you the population with all vascular diseases by age, and you can see at 80, it's right around 80%. Women are a little bit higher than men. Of course, by 80, there's probably more women, than men still alive. So, but when you're younger, there is still some heart disease, even in the 29, 39-year age group. But really, it's after menopause in women. Once you hit 55, it goes up significantly. And here's acute MI mortality by age and sex, and unfortunately it's blue on blue, so you can't see it very good. But blue is women this time, and women have, especially when they're younger, higher mortality, and then it's more equalizes as they get older. Like I said, women have smaller vessels. They tend to have a higher in-hospital mortality after a heart attack. And so women don't do quite as good, especially when they're younger with heart disease. Symptoms of heart disease in women and men are a little different. Women, sometimes it's just fatigue. There's been some reports just of nausea. But the classical history for heart pain in the men and women is pressure in the chest, usually on exertion. Women often don't get as much pressure. They may call it sharp, so a little bit different description. Women often complain of jaw pain and arm pain more than men. But fatigue is a big one. They had a big study, I think, in Scandinavia, where they took middle-aged women. They just kept doing EKGs annually. And 9% of those women had heart attacks that were totally silent. So if your doctor says, let's do an EKG, you better get one done, because that might tip him off or her off that you might have some underlying heart disease and not even be aware of it. So what we're trying to do is educate people out in the communities the best we can, and so really half of the work is for the doctor and the other half is really for the patient. So try to get the patients and the population more knowledgeable so they can help themselves. Now, risk stratification, I think didn't we give them the Framingham, Karen? You all should have a double form called that's from the Framingham study, and it's for women only. But you all can calculate your risk. Now, that's, of course, an older study. It doesn't include diabetes and family history, which are both risk factors. But you can still get an idea of what, your risk factor sort of percentile you might be in. And that might be fun if you all want to do that. But they're the major things that we talk about continuously in the healthcare profession. Smoking. Smoking is just terrible. I was talking to some people today. Smoking may account for 80% of the deaths in women. I mean, it's huge. Higher lung deaths, cancer deaths, heart deaths, vascular deaths. It's not just the lungs. And half of all women that have a heart attack smoke, 50%. So smoking is very bad. High blood pressure is bad. High cholesterol in women, the HDL is more important. The total cholesterol is less important. Women tend to be more sensitive to triglycerides, so if a triglyceride greater than 400 is considered a heart attack risk factor. Family history, especially if they're younger women or younger men. Siblings, I think, are the most important, at least in my practice. If a sibling had a heart attack, you bet I'm going to do a stress test on the other sibling. And obesity, physical inactivity, and poor diet. And today we have a healthy diet for you all, believe it or not. That's what took so long. Even your desserts are healthy heart. And the metabolic syndrome, those are the people that have a big middle. They have glucose intolerance, high blood pressure, and they have a higher risk. So lifestyle interventions is what you do, really. All we can do is counsel you and educate you. We can't like sit at home with you when you're eating, but they're very important. Smoking cessation, if my patient said they do one thing for me this year, I would pick smoking, to quit smoking. And my goal is to quit everybody by 50, and my nurse and I, Felicia, have a thing right now. We're trying to identify our older smokers. You know what? I don't have a lot of older smokers. They've all passed on pretty much. I have very few smokers in their 70s. So I think then that you all can do that too, you know, and you'll realize right away that people that keep smoking don't live as long as the ones that have quit. Physical activity, and it can be anything, but that helps. The healthy heart diet like we did today, and of course weight reduction and maintenance. Now I'll tell you, with weight reduction there's no data that will decrease death or heart attacks, but we still recommend it. And this is a nice slide, iLock. It talks about relative risk of smoking, and I had to ask somebody, but there's 20 cigarettes in a pack. And this was, if you smoke 15 cigarettes a day, that's not even a pack. Your risk is 5 times higher than if you'd never smoked. So you can see smoking is just a huge risk for all vascular disease. And here's a risk reduction. I wanted to show you an exercise. There's pretty good data on exercise, actually. And this is in women that exercised, and they were by quintiles. And the 5th one was that one that did the most. That's 3 hours of exercise, moderate exercise a week. So, you know, 30 minutes, 6 days a week. But it could be like gardening. It didn't have to be, you know, a real aerobic. There was a 35% reduction in heart attacks. So that's a pretty impressive slide. Here's another one, is low-risk diet is associated with lower risk of myocardial infarction in women. And the people that ate the healthiest did have, again, about a 20% reduction in heart attacks. So more vegetables, fruit, fiber, you know, fish, really limited meat. And, you know, you can do this any way you want. You know, basically, I think you have 21 meals a week, and I wouldn't recommend meat more than 7 of them. And of those 7, I'd probably do 2 with fish at least, and maybe beef once a week. So something easy like that you can remember and kind of follow. It's not that hard once you get into the hang of it. And then the body weight, and you can see there's no doubt that the heart disease mortality now, death, among women with the higher body weights is definitely higher. So the ideal body weight was 25-26. BMI, which very few people actually are 25, 26. Most of my patients are there or there. But it doesn't necessarily reduce your risk if you lose weight. It does help in other, you know, areas. There's a higher risk if you yo-yo. So if your weight goes up and down, you're at a higher risk for heart disease, even if you're on down. So you want to lose it and keep it off. You don't want to bounce around. Medical interventions, I think screening is very important, and this is a little bit hard because all the screening tests for heart disease have never really been approved for screening. So we can't just get a stress test on everybody, you know, unless you want to cash pay. And so that's a limiting factor, but we can do it if you have symptoms. So if you're really tired and we think it could be your heart, we'll still code it as heart disease and Medicare will pay for it. For screening stress tests, women do a lot better with nuclear tests. They tend to have a lot of false positive stress tests. So if you do additional camera images, you get more specificity and so more accurate diagnoses. So screening, a lot of times if you have high blood pressure, I'll do an EKG on everybody every couple years. You know, if you had a silent heart attack or any abnormality on your EKG, it's going to pay for a stress test. There's very few patients that I have in my practice that haven't had a stress test, you know, that are 65, very few. I've been here, I just figured out, I did come in 03. So I've been here going on 8 years. I've only had one patient, and I am one of the busiest doctors that works for ETMC, that's had any heart problems that I didn't know they had heart problems. So just about all my people get screened. And symptom recognition, like we talked about, it can just be fatigue, just kind of feeling, you know, not right, maybe sharp pains in your chest, maybe a little shortness of breath. The best case I had was a 39-year-old female, worked for the senator in Alaska when I was there. And she was healthy. She was jogging 10 miles a day, and she came in and said, you know, I'm only jogging 5 miles a day, and it has to be flat. I get more short of breath, and I can't go up the stairs at the Senate building anymore, run them like I used to run them. And her parents, only child, parents were 80 and healthy. So I said, well, gee, let's do a stress test. She flunked her stress test. She had left main disease. They call that the widowmaker's disease, but the main artery, the branch that goes to all the other arteries, was blocked. So she had heart surgery at 39, premenopausal. So sometimes it's just, you know, what she said, I just can't run as far. And that's probably one of the most remarkable cases I ever had because of her age and because she was still running. Treatment is very important. Blood pressure and cholesterol and diabetes, and the doctors can help certainly with these. The blood pressure definitely has to be less than 140/90 after 10 minutes of rest sitting. And don't take it every 5 minutes, because if you do that, it's going to start going up. Because you'll be getting really anxious and nervous. But try to take it once a day. You should have a home cuff if it's running high, and it should be that way. And you can't write it off if it doesn't always go there, like, oh, well, I forgot my pill. I took my pill late. You don't want to do that. If it's really running high, you're going to need to see your doctor and get more treatment. And optimal is probably less than 130/80. We're going to get another revision of the guidelines for blood pressure. We think they're going to go up a little bit, but they'll still say a little bit low for diabetes. They're definitely not going to go higher than 140/90. But for diabetes now, it's 130/80, and they may go up a titch on that. It takes a lot of drugs. Each drug makes the blood pressure go down about 10 to 12 points. So, you know, if your blood pressure is 180, it's going to take at least 3 drugs. Now, if you lose 10 pounds, that counts as a drug. So, you know, 10 pounds is 10 to 12 pounds, and most people will be the same as taking a blood pressure pill. And, of course, following the low-salt diet. So you could actually get maybe just 2 pills if your blood pressure is 180 systolic if you lost the weight and followed your diet. And the lifestyle modifications, of course, there's a DASH eating plan, lots of fruits and veggies, the restriction to, and you know, I usually tell my patients 2 milligrams per day of salt, but if you start reading labels, you know, you can get that really fast, especially in canned foods. Increase your physical activity, no more than 1 alcohol drink a day. You know, we can tell who drinks because they're, you know, especially if I see them on a Monday, it's a trick because people tend to drink on weekends. So if their blood pressure is high and I see them on Monday and they had a little drinking binge, their blood pressure will be sky high Monday. And then I just see them back on Thursday and it will be normal. And then I know they drink. So, but you only about, you know, no more than 2 glasses wine. Red wine's the best. But you got to limit your alcohol. In the cholesterol optimal levels, the LDL should be less than 100. Now, it's not quite as important for women, but the HDL is real important, more than 50, and triglycerides less than 150. And then the non-HDL, which is the total cholesterol minus the HDL, should be less than 130. And we treat for this. And the important thing is, when you think about cholesterol, even if you have half of all heart attacks are in people with normal cholesterol. So cholesterol is not the only answer. And a lot of people think it's the inflammation, and that's why we harp on the statin drugs nonstop. I know the patients get tired of this, but statins, you know, there's several on the market now, and a lot are gone generic. And those are drugs like lovastatin, simvastatin, atorvastatin. You all have heard a lot of these names, and they have the best data by far. In fact, if we found the fountain of youth with one class of drugs, it'd be this class. And they have much better data for men than women, but we still do have some data in women. But in men, you know, probably a 35% reduction in death. You're not going to find a lot of doctors over 50 that aren't on one of these drugs. So what we normally do, in the women, they have data about a 35% reduction in heart attacks. The women did not make the death for the studies, and actually were excluded from a lot of the studies. So we don't have as many studies in women. But most people will start on these drugs first, just because even if a normal cholesterol and heart disease, I'll still probably start one of those drugs because of the anti-inflammatory effects. And if you fail it, usually it's muscle aches and pains, then I'll try another one. So this is when the patients get really tired of this because there's so many of them, we keep going through these drugs, and hopefully we'll find one that you can tolerate. That's because there's not any other class that can touch the death data and the heart attack reduction data of these drugs. I mean, it's not just getting the cholesterol down, because I already said half of people have heart attacks have normal cholesterol. We want the cholesterol down, but we want the risk of heart attack to go down and the risk of death to go down. You got a drug that does 30% of that. I mean, there's just nothing else that we have on the market like that. And statins are probably the most studied class of drugs ever in the history of the United States. Very well tolerated, very not really serious side effects, rare. And so they're tolerated well. You do have to be followed on them. And sometimes you need additional agents for your triglycerides, niacin and fish oil, but none of those have great endpoint data by reduction in heart attack or mortality. And you can try to raise your HDL. Sometimes, niacin might raise it a bit, but exercise will raise it a bit, and some of our drugs raise it also. But it's hard to raise the HDL. And here's coronary disease mortality in women with diabetes, and you think and look at that's the diabetic curve, the split curve, and the straight blue is women without diabetes, and they were followed for 23 years. So diabetes is a huge risk of heart disease. Aspirin, it's kind of, we used to say aspirin for everybody over 50. There's a study last year that said actually in a lot of people that because of bleeds, especially CNS bleeds in the head, that maybe aspirin wasn't really right for everybody. But certainly anybody with known vascular disease, a heart attack, leg disease should be on aspirin. Otherwise, most people probably should be talking to their doctor because this is kind of changing right now. And so in summary, heart disease, cardiovascular disease is the leading cause of death in women. 1 in 3 at age 65 will have some sort of vascular disease. Everybody should recognize the symptoms. I think everybody should get screened, at least by the time they're 65, for women probably, and should work on their risk reduction. And you might say, well, how much is diet? I gave you a fat handout and on fats, the good fats and bad fats. And basically, I did have, they said if you ate more monosaturated fat, if you changed that by just went up 5% in monosaturated fats, that your heart disease risk would go down 19%. So changing your diet does really make a difference. And it's really not that hard to develop a pattern that you can still enjoy your foods but be healthier at the same time. And now I'm done, so I think I'm going to open it up to questions. Yes?
I have a question. You didn't mention anything about a person who is very stressful, in control of stress.
Yeah, I think stress is important in both men and women. Certainly women have a higher risk since they started working more and having more stress. Also, depression is a risk factor in women. But not as strong as these other risk factors, but they still do have a significant increase in heart disease. Good question. Yes?
How often should you do a stress test?
A stress test is debatable. I mean, it's good for a year. Like if I'm going to do surgery, I don't like it going much more than a year from a stress test. If you're really active and you have no symptoms, I think you can go, 3 years, 5 years.
So if you have a negative stress test, meaning everything is fine, no blockage?
Well, not necessarily, because there's at least 1% of stress tests that are normal that do have blockages, so they're not 100%.
Okay.
But they're pretty good. If you have a really good stress test and you're active, I'll usually do it every 5 years.
So if you have no symptoms, you're okay?
Right. But if you're not active or you get any symptom, I'll do it. I'll do it for heartburn. You come in, because think about it this way, everything's innervated by the same nerves in the chest, the esophagus, the heart.
I had one done
Yeah.
because of esophageal.
Right. So a lot of times I'll say, okay, it's probably heartburn, but we can't be sure by your symptoms, so we're going to do a stress test first. I mean, reflux is not going to kill you. Heart disease will. Yes?
Would you discuss the relevance of C-reactive protein tests?
I think the higher it certainly is related to inflammation. And we know there's more heart disease and vascular disease in patients that have a lot of inflammation. You know, patients with rheumatoid arthritis and lupus. It's not a good screening test, though. You know, it's up when you have renal failure, and so it's still not approved for screening. But if it's really high, you know, if you really wanted one done, and it was really high, then, you know, you certainly be higher risk of having heart disease. Nobody's going to pay for it, though, you know, to screen. It's not an approved screening test. Yes?
We can't hear the question that they're asking. We're just hearing the answer.
Okay, let me repeat the question then. Yeah, the last question was about the C-reactive protein. Did somebody else have a question?
If you're I can't take statin drugs. I can't get out of the bed. I can't get out of the bathtub. I can't do anything. But is there anything else now? I have high blood pressure and I don't have cholesterol. But my high blood pressure, since I've stayed off of salt in the last month, has dropped from 150 to 110.
Okay, good. So here's a lady with high blood pressure that she's got under control, but she can't tolerate any of the statin drugs. And it depends on your triglycerides. If your triglycerides were high, I'd use something for triglycerides and something that would increase the HDL, because those are independent risk factors in females. But you know, you certainly can do fish oil, coenzyme Q10. They have data, but nothing to compare with statin data.
I know, because I was on it and I had nothing the time she got through it, but I couldn't get out.
Yeah, and there's certainly some people that just, you try statin after statin and they just get these muscle aches, and, you know, you have to weigh quality versus quantity. Yes?
Did you say to wait 10 minutes before you sit down, 10 minutes before you take your blood pressure? And
Yes, the question was when to, you know, take your blood pressure when you're relaxed, you've been sitting down for about 10 minutes. Now, because when you rush around and do things, your blood pressure is going to go up. You know, I put people on the treadmill just about every day, and I've been doing that for over 25 years. And I will tell you, everybody's blood pressure goes to 180 to 200 during exercise. So you don't want to be, you know, you want to be kind of relaxed and calm, or your blood pressure is going to go up.
well, the doctor's office always weighs you and then takes your blood pressure.
That's a good point. Yeah. I mean, you know, sometimes if you think the blood pressure is high, we do have the ambulatory blood pressure monitor. You know, there's been studies on that, though, and, you know, people that they have the white coat syndrome and their blood pressure is always up. They actually do have higher risk of heart disease, though. So, but you can wear one of the 24-hour monitors. You can take your blood pressure at home if you really think it's just up in the doctor's office. But if it's really up, you probably need to be on something. If it's up more than down, you probably need to be on something.
Well, let me ask another question. If your blood pressure is around 120 or 16 or 10 over 65, is that way too low?
No, unless you're symptomatic, probably the lower it is, the better it is.
Really?
Right. Unless you're dizzy or something like that.
Well, sometimes I feel like I'm on it, you know, I have to sit down,
But so you can be over-treated, but, you know, we don't like it, the top number less than 100. I mean, we want everything to perfuse adequately, all the organs. So if the blood pressure goes too low, you know, sometimes the organs
well,
will...
what is too low?
I would say less than 100, but certainly people with heart failure run about 80 on the top number. I mean, it depends on, you know, if you got a bad pump, you're not going to have high blood pressure sometimes. And we're still having them on blood pressure medicines to treat their heart failure. So some people always run low and will tolerate that. But if you're dizzy or symptomatic, then it's too low.
Well, I think what's helped me, I've walked all my life 2 miles, and I'm 85, and I can still walk 2 miles.
Yeah, so you've been
Every day
active.
I want to do it.
Yay. And she just hit on the key. The people that are active tend to do better as they age.
It's the walking. If y'all walk, you got to make it.
I'm sorry, do you recommend the CoQ10 then for?
I do, you know, it's not a strong, I do the statins first, but the CoQ10 does have some data, and so I think it's fine if you want to take it.
HDL?
So CoQ10 would be fine. Yes.
How much per day?
You know, it depends on which one you pick up. So I just say, you know, whatever the bottle says.
Can you take fish oil and CoQ10?
Yes, you can take. Yeah, I just wouldn't do fish oil. I don't like fish oil before surgeries. It tends to make you bleed a little bit more.
Well, I take fish oil.
Yeah, but fish oil's got some data, not tons, but some data.
What about red yeast rice?
Red yeast rice in the controlled studies did not turn out well at all. Very little data, no benefit probably. Yeah.
Can you repeat that question?
The red yeast rice, in most of the controlled studies, it was of no benefit. Yes.
I just read that if you take statins, you are 5 times more likely to have breast cancer.
You know, I've read that. I don't think that's proven yet. But, you know, there hasn't been a study on that. You know, the trouble about when you read these things, they go back and they may ask people questions, but you have to have a study set up front, a controlled study, so we don't know the answer for that yet.
And if you have a stent put in your leg, should you stay on Flash Soap?
If you have a stent in your leg, should you stay on?
I don't. My mother did.
And stay on Plavix, did you say?
That's right.
Yeah, you know, whatever your vascular surgeon says, but generally they leave people on Plavix. You know, most of the heart doctors say, you know, once you have a stent, if you can afford it, you have no side effects, you know, indefinite Plavix, but it's still quite expensive. Any more questions? Yes.
I noticed that caffeine is to be avoided on a cardiac diet. What's the latest thinking on caffeine, just generally talking?
I think, you know, I'm pretty neutral. The question's about caffeine. I'm fairly neutral in moderate amounts. You know, there's been some studies that coffee drinkers live a little longer, and green tea and all. So I think it's all a wash with caffeine. Yes.
Is grapefruit still taboo for statin users?
You know, you're not supposed to do it, but I think I have a lot of patients that do it that don't have problems. But you shouldn't. And your statin's best taken at night, bedtime. Any other questions?
One last question in the corner back there.
Yes, in the corner.
Can you tell us a little bit about metabolic syndrome?
The metabolic syndrome. The metabolic syndrome, well, the best description is the guys with the big tummies. Those guys. Okay? And their sugar is a little high. They're really not diabetic, but their sugar might be like 105, 110. To have diabetes, you have to be a 126. So their sugar's a little high, their triglycerides are high, their blood pressure's high, and that's the metabolic syndrome. And it carries risk for lots of things, diabetes, heart disease, definitely. A lot of Americans do have the metabolic syndrome. Yes?
We had one doctor recommend to my husband vitamin D3 would be
Oh, there's always a question about vitamin D. So the question is about vitamin D3. Everybody talks about vitamin D3. The only good studies include bones, definitely if it's low, and falls and muscle weakness. Those are the only things that turn out good in the studies. But they've linked vitamin D3 to just about everything. But the only things that have statistical significance would be weakness of the muscles and bone problems, osteoporosis. Certainly I can tell you the number one reason to be in a nursing home is falls. So the muscle weakness is part of the falls, and I screen my patients for D3 deficiency. I'd say in East Texas about a third of them are, 30 to 40%. So I would get it screened mainly for the fall prevention and for the bones. Yes?
I've been taking off all caffeine and chocolate. And I can't understand that you say
Because of heart disease or? Yeah, well certainly chocolate's very high in fat, unless you do that. Now dark chocolate actually has some heart data, protective heart data. But we're talking, one small little cube once a day. Yeah, and that's the dark chocolate. So it does have some protective heart data there.
good cholesterol real high.
Yeah, that's a difficult, because if your good cholesterol's high, I gave you the Framingham risk factor, that takes a point off on your risk factors, so that's helpful. Yes?
What about statins and Tylenol?
Yeah. I think you can take them together. The new recommendation for Tylenol is no more than 2,000 milligrams a day. And, a lot of the pills are 500, so that, 4 a day would be the max. And some of the pills are 650, so that would be 3, basically. So Tylenol, definitely the doses are going down. But to tell you that I've only seen one person die of Tylenol toxicity. Although if you look at the statistical data, especially in England, Tylenol was at one time the #1 reason for drug-related death. But it's just something that I just don't see much in my practice. Other questions? Okay, great. Well, thanks everybody for coming.